All right, so classification of neoplasm, how we're going to classify it, which is another thing, another way that I classify it as opposed to the book. It's all there, it's just two ways of seeing it. So neoplasms come from three different sources. Okay, just three. One of them could be subdivided into many, many, many. So we could have neoplasms from a totipotent cell. Remember how we had a totipotent cell? It could be anything at once. Basically, a sperm goes into an egg. Now you've got one cell. That cell turns into this. That one cell could make a liver cell, could make a muscle cell, could make an eye cell. It could be anything at once. It's totipotent. Okay? So it's capable of becoming any cell. And germ cells are the only totipotent cell that we have left over after the embryo and fetus that we were in our mother's womb. The only thing we have left over is these totipotent cells in the germ cells. Basically, your ovary and the testicle. It's the only place you could actually have these germ cells. So findings of all these three germ cells is going to be found in that tumor. Kind of a weird thing. That's why I had that slide a while ago showing you ectoderm, mesoderm, and endoderm. Endoderm, ectoderm, mesoderm, what they give rise to, all these different things. And you see some weird things happening with these tumors. They're usually benign. But like an ovary, if it gets large, because they could grow pretty big, even though it's benign, it could be dangling from the ovarian artery. And if that gets so big and it twists, a certain way you walk or you fall down, you're playing hockey or whatever it is, and it twists, it can twist so much that it can kink the blood supply going to the ovary, and that's the only blood supply. You could lose the whole ovary because no oxygen goes there. It gets necrotic. So keep in mind, benign does not mean not dangerous. It just means it doesn't spread. Okay? Usually found, like I said, in the gonads. All right? Usually testicle and ovaries. And they're called teratomas. And this is what one teratoma looks like. This is an ovarian, we call it dermoid cyst, also known as a teratoma. It's nasty looking. But look, you get all the germ layers. Let me just finish. The little germ layers. You get teeth. You get hair. All this weird stuff. Because it comes from ectoderm, mesoderm, because all these weird stuff. It could become anything at once. Remember, it could go through mitosis and stuff. We usually see this. I think I pulled, this is an ovary. I think I pulled out about a dozen different dermoid cysts. It's usually in the childbearing age, too, that I've seen it. Anywhere from like 14 years old to like, 35, 40 years old. The youngest one I took out was probably about a 16-year-old that had this. But these are benign, but we have to get it out because first, we can't tell what it is. Is it cancer? We do an ultrasound? Because it looks all nasty in here, so we're not too sure. But it's getting bigger and bigger, so we've got to remove it. Hopefully we could just remove the tumor and salvage some of the ovary, but sometimes it's just too big, we can't salvage the ovary. If she has the other ovary, so she still get pregnant, but if they get really weird looking, dermoid cyst. All right. So that was one thing, the totipotent. It's coming from a totipotent period. Then we could have a neoplasm from embryonic pluripotent cells. So these are cells that are starting to become differentiated. It's not that they can't. It's not that they can be anything they want. It's more like if they're going to be a muscle cell now, they could be a cardiac muscle cell, a smooth muscle cell, or a skeletal muscle cell. It's getting more specific, but it's still could be a lot of different things. Okay. It usually occurs early in childhood. These tumors, we don't usually see them as adults, and these are usually malignant. These are usually things where the reason why we see it in children is because they're still developing. Their neurons are still developing. They're usually called blastomas. So a nephroblastoma, also known as Wilms tumor, but a nephroblastoma is a kidney disease of a pluripotent cell that affects children. All right? Retinoblastoma. There's also neuroblastoma. So all of these, if you hear blastoma, you're thinking germ cell. They're usually in children. Okay? And the last one is neoplasms of differentiated cells. This is what the majority of cancers that are out there. Okay? Because now it's like a liver cell can become a liver cell. An eye cell can become an eye cell. They're very specific. So these make up most of the cancers in the children and adults, okay? And these are most common forms of cancers is this, okay? So let's break up that further. So we're looking at this, neoplasms of differentiated cells, and we're going to subtype all those, okay? So these are the three subtypes. If it has the word carcinoma in it, that's epithelial origin. Okay? You got to go back to histology, chapter 4 in A&P. Any of the epithelium tissues, we call that carcinomas. If you remember epithelium will give rise to glands, mammillary glands, salivary glands, all right, and so forth. And they'll also cover the linings of cavities. So the lining of the intestines, the lining of blood vessels, the lining of lungs, the lining of anything like that, okay? The lining of the uterus, the urinary bladder, okay? So that's what it is. So carcinoma or epithelial tissue is glands and lining of cavities. Skin, it's the lining of the cavity. What cavity? The outside world. 85% of all your cancers are epithelial in origin. 85%. Okay? 10% go to connective tissue. All right? And if it's from the connective tissue, we call it sarcoma. Okay? Or if there's smooth muscle carcinoma, or I'm sorry, smooth muscle origin, we also refer to it as sarcoma. Okay? So that's where that comes in. So here you got 85% of all your cancers. There's 10% of all your cancers. There's only 5%, which will be, well, it's all this kind of stuff. Leukemia, lymphomas, okay? And then we have, keep in mind that the neurons, skeletal muscle, and cardiac muscle are rarely, if ever, they become cancers. Because one division of a neuron to two daughter cells takes about 70 to 80 years, if it's going to happen. All right? But skin cells, 8 or 9 minutes, it's making 2 cells right away. There's a great chance of mutation. Okay? So this is just showing different places of the epithelial origin. Here's different places of the connective tissue. And different places of muscle. Okay? So you got to review that stuff. You may have to. There's a short 3 slides to show that is. Okay? And this is just, again, carcinoma, sarcoma, and chart form, what this is. Okay? Then we have a list of, not really a list, we've got 2 things that really break up. Miscellaneous tumors that don't fall into those categories. Okay? A mixed tumor. So it could be 2 types of epithelial tissue, or it could be epithelial tissue and a connective tissue. It's mixed. That's what this is. They're rare, but they're there. Then you have this other weird one called carcinoid tumor. And we usually see this in the digestive tract. They're slow-growing malignant tumors that rarely metastasize. And so they don't behave as most cancers do. That's why they call it carcinoid. But they're usually in the digestive system. And we do usually see this where it releases serotonin, that neurotransmitter. I've seen 2 cases of this, and they were both in the appendix. So they removed the appendix because it looked inflamed. It acted like, you know, looked like a duck, smelled like a duck, walked like a duck, and thought it was appendicitis. We did the biopsy, turned out to be carcinoid tumor. We usually see it with the appendix. It could happen anywhere in the digestive system. This is where I'm trying to train you guys for these NCLEX exams. They kind of are going to throw things there. Here's a patient who has a malignant tumor that's on the appendix, but it definitely does not metastasize. What blood level would you want to get of this person? And they'll have da-da-da-da, serotonin, da-da-da-da. See? That's where you got to put it together. You have to try and apply this stuff. There's little pointers here that I try to give you, these pearls. If you think of, appendix doesn't usually become cancerous. It does this weird thing, but not cancerous. So if you're thinking that, then think of carcinoid. That's what that's what I'm trying to train you for with the NCLEX. These little pearls. Okay? All right, then we have these Pananeoplastic syndromes. This is very common. I see this a lot on board questions. I've seen on NCLEX. Basically what happens here is that even though the tumor is happening in the lung, then why is the rest of your body doing this? In other words, if your tumor is in the lung, why are you anemic? Why do you have muscle weakness? So even though it's happening in the lung, why are you getting these systemic issues? Pananeoplastic, like pandemic. Why do you get this whole thing worldwide? Okay? These they like to ask. All right? So 10% of cancers have these syndromes. Many side effects or signs and symptoms are just idiopathic. We just don't know the reason why. Other symptoms we could explain. Like I said, you've got lung cancer, you have high blood pressure. Maybe because this is releasing an ADH-like hormone that's making your blood pressure go up. I'm noticing that my calcium is up. I got lung cancer. Or maybe because it's releasing a PTH-like hormone. So some of them do make sense, but some of them don't. But it's important to know these because a lot of times that's the part that's going to be the first symptom that you see. For instance, if you have high blood pressure, just seeing your doctor, an incidental finding, hey, my blood pressure is 160 over 110. Pretty skyrocket up. Could it be just what we call essential hypertension? Or is there something else? Let's do a chest x-ray. Lo and behold, we'll see a little lesion there, coin lesion. That's usually typical, say, with lung cancer. You see these coins over here. But it might be the first sign of cancer. Now, I don't want to scare people. I don't want people to think, oh my God, my father has high blood pressure. That means he has cancer. No. But it just makes you want to see other things. That's what the internet does too, right? They can be lethal. I mean, you could have, let's say, ACTH, like hormone that comes out, and it makes your cortisol go skyrocket up. That could cause major problems. Okay? And because they come out, as I just showed you, the diagnosing could be a little brutal. We don't know why you have the high blood pressure. Kind of weird. That's not, believe me. Even though I'm just saying this over here that lung cancer can cause high blood pressure, it's not common. But it can happen. So high blood pressure, they're not going to do the chest x-ray right away because they're not thinking that way. They're thinking of the more, is that a horse or is it a zebra? They're looking at, they're not going to start looking at zebras. You're going to look at the more common things, right? That kind of thing. All right? So this is why they love to put that stuff on there. How do you explain anemia? A lot of times you just can't tell. Okay? So examples. I named off a few. Hypercalcemia, right? Certain cancers will release a PTH-like hormone. That's probably the most common thing, all right? And that's one of the things. If they just do calcium levels on you and they see them high, skyrocket up, one of the first things in this case they will be thinking of is cancer, okay? Where? We don't know. You could also have something called the syndrome of inappropriate ADH, okay? SIADH. ADH is antidiuretic hormone. So this is going to release an absorbent amount of ADH. So in a person who has SIADH, what happens to their blood pressure? When ADH comes out, does your blood pressure go up or does it go down? It goes up, right? Right? If it's producing a lot, ADH is going to reabsorb water. Right? Here. Right? So if we increase ADH, antidiuretic hormone. Antidiuretic. Diuretic means to pee, right? So antidiuretic means you're not going to pee. So what happens to your urine? Increase or decrease? Antidiuretic. Antidiuretic. Diuretic means I'm going to pee. Antidiuretic means I'm not going to pee. So what happens to the urine volume? It's going to go down, right? Right? Antidiuretic. Does that make sense? If I give you a diuresis, if I give you a diuretic, Lasix or something.
You have to go to the bathroom a lot.
Right, that's a diuretic. So if you're going to drink coffee, you're going to pee a lot.
Now I get it.
So if you get an antidiuretic, you're not going to pee, right? Does that make sense?
Yeah.
Right? Does everybody make sense? So if that happens, then this water that normally goes in your urine doesn't go in your urine. What happens to your blood volume? It increases. If your blood volume increases, what happens to your blood pressure? Okay? Step by step. All right? So if that happens, that's what happens with syndrome. That's what I mean. If you know what ADH does, if you have too much of it, you know what's going to happen. If you have too little of it, you know what's going to happen. That's why you need to know A and P. See, I don't have time to review what ADH is, but the rest of it's all gravy once you understand what it does. Just do step by step. Right? So that's what an example is over there. Right? So we call that disease, and we'll get into that with endocrinology, syndrome of inappropriate ADH. Cushing's syndrome could secrete a cortisol-like syndrome, which again, if you increase cortisol, how that all affects over here, which I'm not going to do for you, but you can do that at home. All right, when we get into endocrine, we'll get into more details about that. It could cause a decrease of glucose. Okay, and it could also cause clotting, which we'll talk about in a little bit. All right, so it could cause deep vein thrombosis. Other things it could do is cachexia, right? You look like a bag of bones, as I said. You get this tumor that grows and grows and grows, and it's stealing all your nutrients that would normally go to all your normal cells. So these people, about 50% of patients with cancer have cachexia of some sort, and it's basically starvation is usually because you're taking away all the fat loss. It's mostly fat loss that's happening here, okay? Loss of weight with weakness, lethargic, you get some anemia going on here, and you get anorexic. Now, anorexic does not mean just what we call anorexia nervosa, right? You look in the mirror, and you look at someone who looks very fat, so I'm not going to eat. But that's what they see. That's messing with the mind, right? That's anorexia nervosa. That's not what I'm talking about, right? That's see people with anorexia that you see on. But anorexia just means poor appetite. That's all it means. In cancer patients, you increase metabolism because these things are growing and growing and growing. All right? In cancer patients, it's unable to make proteins efficiently. Your muscles are loaded with proteins, actin and myosin. So now you're not going to be making all the actin and myosin, so therefore the muscle gets wasted, right? You get this wasting, atrophy in your muscles of the arms and legs. So they start getting thinner and thinner. So if you have anorexia, you get increased metabolism, decreased proteins, you're going to have severe weight loss. You'll have this cachexia that's happening. And you have these kind of pictures that go on like this. But that's what that is. It looks like a bag of bones.